Hey folks, welcome back to the reading room. I'm Ryan, and this is our series where we go through great radiology cases in small animal practice to help you elevate your radiology game and become a radiology rock star. This week we are taking a look at a case of a German Shepherd cross who presented with respiratory distress to a clinic. And as always, this is the clinic that I provided in the Obi weekly newsletter, weekend-rounds.beehive.com. Check it out if you haven't already. You get early access to these cases, get to participate and vote on what you think is going on, and then follow up with these case recordings each week. So these are the images, and the question that we wanted to know is what folks thought was the most likely thing going on in this patient. And this week we actually had a really divided answer on what we thought was happening in this patient. 7 people said lymphoma, a few people said pulmonary carcinoma, a few people thymoma, and others fungal pneumonia. And in this case, the actually correct answer is lymphoma. And let's take a look at the radiographic signs that point us towards lymphoma being most likely over the other ones, and what some of the other reasonable differentials are and why we might rank them differently. So in this example, one of the main findings that I think a lot of people honed in on was this rounded soft tissue opacity in the cranial mediastinum. It's located right here, and in the ventrodorsal projection, we have mild widening of the cranial mediastinum. The other thing that I'd really like to note, though, is that that's not the only place in the mediastinum where we have an abnormal opacity. We also have this increase in opacity at the heart base, and this is an additional similar finding within the mediastinum. When we put both of these features together, this is actually evidence of intrathoracic lymphadenopathy. We have the cranial mediastinal lymph nodes as well as the tracheobronchial lymph nodes, which are located here and across this region here. This is a really important thing to kind of put together and see both of those present. So as soon as we have lymphadenopathy in multiple areas, we'd be looking at either neoplasia or some sort of marked infection. The other thing that we can look at and note in this patient is that there is a pulmonary pattern, this unstructured interstitial pulmonary pattern throughout the lungs, which is really visible in the ventrodorsal projection, which I didn't give by email, but we've got this increase in opacity of the lungs, which also tells us that there's lymphoma infiltrating the lungs in this instance. So this is a case of a dog that has multicentric lymphoma. There is cranial mediastinal lymphadenopathy, tracheobronchial lymphadenopathy, as well as an unstructured interstitial pulmonary pattern, which results in overall clinical signs of the dyspnea in this dog, and the radiographic findings are most compatible with lymphoma. What are some other differentials that we could consider? Well, if I had to rank a second one of the answers that I offered in the newsletter, it would actually probably be fungal pneumonia. The combination of the pulmonary pattern with the lymphadenopathy, fungal pneumonia would be a secondary consideration for me, but much, much less likely in this instance. So the question becomes, what about pulmonary carcinoma? Well, I think that the location of this mass, while we don't have the orthogonal projection, we should be most likely thinking about a mediastinal origin rather than pulmonary. If you only have the one projection, certainly it could be pulmonary. But again, those other findings are pointing us away from it being in the pulmonary parenchyma. And then if we think about thymoma, one thing that we can do is try to consider first the additional lymphadenopathy, which really points us towards the lymphoma, but then what is the location of this cranial mediastinal mass and why might it be compatible with a lymph node rather than the thymus? They're quite similar, but this is an example of a patient with a thymoma. We'll take a look at a couple examples here. It's not always true. Sometimes you can have quite a small thymoma, but oftentimes you have a large mass. It's typically left-sided, and one thing that we notice is that it's almost triangular shaped, extending into the cranioventral thorax, cranial to the cardiac silhouette. So the margin of the mass here extends along there. And then in the ventrodorsal projection, it's challenging to see in this dog, but it's actually extending over here to the patient's left side. If we look at another example of a dog, we can see it here on the left side in the VD projection, and then occupying a good portion of the cranial thorax in this lateral projection. These are both examples of thymomas. So you can see they look a little bit different, and neither has that increase in opacity in the area of the hilus, which would be compatible with the tracheal bronchial lymphadenopathy in the case this week. So if we compare those two side by side, in this instance the thymoma occupies a lot more of that cranial mediastinum, extending more ventrally, and then no evidence of tracheobronchial lymphadenopathy. That's really pointing me towards the lymphoma. And if we compare the lungs in these two dogs, we can also see that there's that unstructured interstitial change compatible with the pulmonary lymphoma, which we're not seeing in a dog with something like thymoma. So those are kind of the main findings. I really hope this has been helpful and has helped you the next time you're encountering a cranial mediastinal mass in your practice. Again, if you want early access to these cases, be sure to subscribe to their Weekend Rounds newsletter, weekend-rounds.beehive.com, and I look forward to seeing you next week for another great case.